I looked through as you do, the list of conference attenders, and I was somewhat alarmed to discover that I'm the only GP in the house. I was pleased then to note that you're all rather young and healthy looking. I was hoping I wouldn't be called upon for any medical emergency. Although the most welcome words you can hear in any such situation, and I've been in a few of them, are, "Stand back, I'm a paramedic." And actually, I also feel I'm a bit here under false pretense because I'm not actually a GP anymore. I've recently retired. Which actually, I was thinking that following this morning's discussion that I might have retitled what I'm going to say this afternoon about, why is there only one GP at a conference about safeguarding in relation to children with autism? Because you might think it's a professional group that would have some interest and concern in that subject. And of course, that does raise a lot of issues about the current state of general practice, which you'll be pleased to know we haven't got time to go into. But I come here with some experience as a GP, and I've worked for 30 years as a GP in Hackney. And I also have a long experience as a parent of a young man with autism and severe learning disabilities, who's now 22. And in that combination of experiences, I've had a fair gamut of some of the experiences that have been talked about this morning. I've had the experience of being referred for child protection investigation because my son was engaging in self-injury to such an extent that he managed to punch his face and bite himself that he sustained quite significant bruising, and a child protection investigation was undertaken. I've had the experience of him being excluded for school on the grounds of his extremely bad behaviour and being at home for several months. I've had the experience more recently now as an adult of actually, despite being very careful to try and prevent these situations, of being attacked by him in the street, which is, now he's 22 and bigger and heavier than me, a bit of a bigger problem than it used to be when he was little. And so I've had experience of, I know it's become quite common in the Premiership now of having bite injuries in various parts of your body, having your hair pulled, you're being head-butted. I've some experience of the engagement of the police in such operating. I must say, a very positive experience. I know many parents of children with autism, adults with autism, complain very much about public responses to situations that develop and the way the police. I've every reason to be very grateful for the kindness of strangers and the professional competence of the police in the very few situations that I've been involved in. It's been said a number of times this morning, and I won't emphasise the theme, if you've met one person with autism, you've met one person with autism. And that, I think, generates a certain sense among many people professionally engaged in the subject that, it's a bit tiresome, people representing parental experience as a form of expertise. You're expert in one, N equals 1, as they say in medical research papers, in one particular person. It gives you very limited general knowledge of the subject. So I don't come here presenting any sort of academic expertise, but a degree of personal and professional experience of some of the subjects that have been talked about. And I come to discuss some of the more general issues that arise at this troublesome interface which has been talked about, have been touched upon in various talks this morning and later this afternoon. The troublesome interface between the sort of informal world of the school, the nursery, the GP surgery in my case, and the more formal world of higher expertise, professional intervention, child protection, child safeguarding sort of procedures. And that's a troubled interface. And it's troubled for the reasons that many people indicated, because it's difficult. There are a lot of difficult issues that are thrown up here. The issue of diagnosis is contentious. The diagnostic categories are contentious. The overlap, as we'll talk a bit more about, between autism and mental health, these are difficult areas. And as also has been made clear this morning, the stakes are high. The stakes are high in terms of getting it wrong, missing the diagnosis, or getting the wrong diagnosis. We've heard how from Tim Gilling about when you get a mistaken allegations of child abuse, or on the other hand, we've heard some from Mitzi Waltz about the real situation of parents of children with autism who do abuse their children, indeed on occasions have even killed their children. So these are difficult issues. And one of the experiences I've had as a GP, I mean, one of the things about general practice is I worked in the same practice for 25 years. You know, you live with your mistakes. And I've had the experience of adults coming up to me and saying to me, you know, a child in a family of 3, I remember very, very well, that culminated in the children being taken into care. 2 of the children one had autism, one had learning disabilities, the other one didn't. He came to me 10 years later and said, why on earth didn't you get us taken into care much earlier? You know, and I thought to myself, the energy we put in, me and various other professionals engaged in various meetings to try and keep this family together. 10 years later, you know, why did you do that? He says to me. That's the sort of thing you have to live with. And I've also had the experience of an adult come to me and said 10, even 15 years down the line, told me how, why weren't you more astute than my mother was falsifying medical records, falsifying test results, giving the children laxatives to encourage investigations in hospital, and went through a whole range of hospital investigations and treatments going on for years. You know, the child comes to you many years later and says, why didn't you do something? Why weren't you more astute to recognizing what, you know, would be described as factitious illness? So these are the sort of things that I think you have to negotiate and deal with. We've heard a lot of people talk about a particular recurring theme about the missing of diagnosis of autism in various ways with women, girls and women. And this is particularly, there was an article in the paper last week about this that made this point of an organisation that's now to say, you know, women saying, oh, if only I'd been diagnosed when I was a teenager, I wouldn't have had all these difficulties. Well, of course, there's a parallel organisation not mentioned here of people who say, actually not women, but mainly men, saying, why was I diagnosed as autistic as a teenager? I was inappropriately labelled. It became a self-fulfilling prophecy. It had all sorts of adverse effects for my life, professionals interfering with me, and an organisation, a book has been published, organisation exists. So there are so many conflicting dynamics at issue here that are very difficult, and we've all got to pick our way through these sort of problems. And the other thing I think is also people lose sight of in this thing is the difficulties of context. You know, that we're, I don't know, people watching any of these programs, educating Yorkshire, educating Essex, educating the East End. My other son, who's not autistic, has just completed his first term as a teacher. He's teaching English in a comprehensive school in London. So as a family, we've been watching these programs with some interest. And one of the points he makes about the things like educating Yorkshire is every week you've got the whole programme, you know, obviously for dramatic purposes, focuses on one child, and you get the sense of the entire school, the staff teacher, the teaching assistant, the various counselling, all have a vast amount of time to sit around discussing the problems of one particular child and what can be done about it. Well, you all know in the real world of education, like my real world of the GP surgery, you just do not have that sort of luxury of time and space to discuss the particular problems of it. You've got to do things without the full benefit of the full information sometimes, because situations are quite pressing. There's a lot of pressure. You've got to do things quickly. It's a very high pressure sort of existence, and you're doing it also under a general high level of public scrutiny, because every morning you get up, you'll find a new revelation in the newspaper that says a shocking survey has been produced that shows a full 50% of teachers are below average in their performance. And, you know, this is a shock result. Something drastically must have been done. People must be named and shamed. Teacher, doctor, you know, what if you're any other professional category, it's only a matter of time before it comes around to you. So that's the sort of context that we're all working in. And then, you know, we have our guidelines. Like this is the step-by-step guide for GP practices produced by the Royal College of GPs. That's the guidelines for you know, organising a service for people with learning disabilities in general practice. It's 50 pages long. It's a brilliant document, you know, but it's completely impracticable to be implemented in the GP surgery. I know, because I tried to do it. You know, and that's the problem, is that we've got guidelines about every conceivable subject, that we've got guidelines, and that's guidelines on this particular subject, just from the Royal College of GPs. There's also guidelines from NICE, there's guidelines from Sky, there's guidelines from the NAS, you know, and every other thing as well. One wag in the medical press observed that if all our guidelines were stacked together and you stood on the top, you could probably just about see Andrew Lansley's vision for the future of the NHS. So what I'm, with that rather long-winded introduction, I suppose I'm coming around to trying to I suppose, what would be good to have would be good enough safeguarding, not Rolls-Royce safeguarding, Rolls-Royce guidelines promulgated by people in academic ivory towers who are not actually down. There's a whole world of people setting agendas and other people breaking stones in this, and we're out there breaking the stones and they're setting the agenda. So I think we've got to try and achieve some sort of balance and some sort of, basic rules of thumb, commonsensical sort of things that we can use in the day-to-day, because that's, where we've got to work. Now, if we're talking about autism and mental health in relation to children, we're talking about 4 basic categories of things, it seems to me. We're talking about anxiety, and a lot of them have been touched upon, and I don't want to go into any of them in a great amount of detail. We're talking about anxiety, we're talking about depression, we're talking about OCD type things, and we're talking about behaviour stroke ADHD, if I broadly categorise them in those terms. And in terms of all of them, the crucial thing is you've got to have some sense of a baseline. What is the baseline of the particular child? Because a lot of people have emphasised it's the change that's really significant. And, one of the key things before talking about any particular distinct diagnostic overlaps, as a doctor you've got to be aware of, is there some underlying medical factor that might have precipitated this particular deterioration in the condition or change in the condition. And of course that's a very significant separate issue that always, and a difficult issue too, that needs to be dealt with. So we're talking about anxiety first, and of course anxiety is by far the most common associated mental health problem in relation to autistic spectrum disorders among children and adults. And you can quote the figures of certainly a majority of people in the spectrum experience those sort of problems, whether you're talking about social anxiety, specific phobias, agoraphobia about particular places and situations, or more generalized sorts of anxiety. Early warning signs in relation to anxiety doesn't seem to me to be that much of an issue, because the children with these sort of problems tend not to keep them to themselves. You tend to be aware of them fairly rapidly, and deteriorations become apparent fairly rapidly. And so I don't think the early warning situation is too important. If you come on to depression, I think that's a different situation. Depression is probably less common, but you could say more serious and more worrying in its consequences in the overlap with autism. For obvious reasons, it tends to be missed or delayed. Obviously, if children have a limited communication capacity, then their ability to express their feelings of low mood is limited, and it will tend to be expressed in a deterioration in behaviour. And I think in this context that any regressions in behaviour, and people mentioned these this morning, regressions in general social engagement, regressions in toileting, these sorts of things, you need to be very rapidly kind of attuned to them and aware of them in terms of understanding what they may signify, because certainly picking them up, and particularly in the more, when you're talking about adolescence, and where the consequences may be very serious, where the development of suicidal ideas and indeed even suicidal behaviour and self-injury may develop. Obsessional compulsive disorder of a wide range, obviously obsessions and compulsions are a very familiar part of the autistic range of behaviours and activities. And I think there's an interesting rule of thumb, it seems to me quite useful, that distinguishes between these situations with typically developing children and autistic children, that typically developing children and indeed adults tend to find their compulsives and ritual behaviours that they engage in, tend to find them distressing and discomforting and not pleasant, whereas often actually children with autism seek some comfort in their rituals and their stereotypical activities. And indeed, to some extent, that's why people have experience of working with children will know to work with them rather than directly challenge them, and trying to channel them in particular directions can be particularly useful. And so again, I think there's no, the early warning thing is not so much of an issue there, because you'll become, the behaviours tend to intrude upon the life of the child and for the life of the people around them fairly rapidly. In terms of behaviour ADHD type things, which may manifest itself obviously from quite young age in terms of oppositional, defiant sort of behaviour, and then in the sort of tantrum, meltdown phenomena that I think we're all familiar with, to self-injurious behaviours of various descriptions, and then aggressions of various forms too. That range of behaviours, which of course, as in my experience of my son, becomes more of a problem as they get older, just because they're more difficult to contain and do more damage, both potentially to themselves and indeed to other people. So these are the things that are particularly worrying. Now, then again, I think early warning signs are not so much the concern as the identification of triggers and reinforcers of those particular behaviours. And that's obviously the key thing you always try to identify. What is it that sets off these behaviours? What seems to keep them going? What can help to deal with them? And that, having a sense of those things, having a sense of how those conditions manifest themselves in the autistic child, by contrast with how they are usually, not generally speaking, is the essence of what we're talking about here and what we need to be sensitive to in the school situation, in the general practice surgery sort of situation. What can we do about these problems when we identify them? And here, the issue, of course, for the GP and for the schools is at what stage to refer on to a higher kind of authority or a higher level of expertise. It's quite a difficult issue, and it's an issue that is it seems to me, in my experience in general practice, has changed quite a bit over the years with the development of local service, and you work a lot as a GP in terms of your knowledge of the local services. So if when my son, for example, was diagnosed with autism and the behaviours and all the problems got very difficult when he was 8, 9, 10, 11, we were referred to the Children and Mental Health Services, then Child Adolescent CAMS, Child and Adolescent Mental Health Services in Haringey, which is across the border from where we live, from the borough I work is in Hackney. And in those days, there was nobody knew anything about autism in the CAMS in Haringey. We're talking about quite a long time ago. It's completely different now. In Hackney, actually, there's always been a higher level of expertise. I don't know why, but there's always been very good. And you build up relationships, which I think informally very important to the way I work and the way GPs work. You've been in an area a long time, you get to know people, and that makes a fantastic difference in terms of the quality of care that you can give to families, because you can get on the phone to people, get some help before you make it into a major kind of issue. So that's the informed, but you have to have a sense of when it's appropriate to refer people on to get the expert help that they need. And the kind of levels of intervention, I think you're talking about 3 broad areas here. You're talking about psychosocial, educational type of initiatives, you're talking about more systematic therapeutic kind of initiatives, and you're talking about drugs. And if you talk about those 3 things separately, the psychosocial, educational type of, all know much more about that than I do. And I remember vividly reading in the early days of my son's diagnosis, there's a famous old Oxford textbook of medicine that's only got 1 page about autism in it. And right at the bottom of it says, a good teacher is better than a good doctor in relation to autism. I thought, very true. And a good teacher, I would include a good speech and language therapist, a good occupational therapist, a good educational psychologist. Vastly more useful to a child with autism than a good doctor is. And you, as I say, you know that better than me. But the range of things that is so important in terms of preventing and managing these sort of situations in terms of structure, visual timetables, communication systems, all those sorts of things that are the sort of day-to-day management of children with autism and the management of sensory issues. It's also been raised. I think that obviously those things are fantastically important in terms of, as I said, preventing, managing, dealing with these sorts of problems as they develop, and hopefully preventing them from escalating to the stage where they're going to be a major problem. The next stage of more systematic therapeutic interventions, of course, there's a range of different sort of therapies, of which cognitive behavioural therapies of various sorts are the dominant sort of theme. And in relation to autism, and obviously depending very much on the intellectual level of the child, probably more behavioural than cognitive. using more visual clues, visual representations, more explicit, all those familiar sorts of things that have a good track record of delivering significant benefits for most people that have them. And then obviously there are a range of other alternatives, but that's, I think, the mainstay of therapeutic intervention for pretty well all of these conditions. Drugs. I won't say very much about drugs. You can go into the whole range of that, other than to say, I always interpret a parent coming into my surgery with a child with autism and asking for a medication, that about early warning, that is a red flag situation to me, because that suggests a stage of desperation has been reached. Because that parents are very reluctant to resort to medication, and the resort to it indicates that they're not coping. And so my first response to that is, obviously to explore the problem and the situation, but to get on the phone to the school, to the local services of one form or another, to find out what's going on, to see what extra support can be organised to deal with it. In other words, to try and contain it and get the problem back into a more psychosocial, therapeutic kind of framework. I find that far more likely to be helpful than resorting to medication. I think that's true in general, but it's also specifically because the medication is not that useful. I think, as anybody who's had any experience in this field will know. In a way, there's a long history in psychiatry of the use of drugs in the treatment or a long history in autism of the use of every drug that's ever been used in psychiatry, if I put it that way. In the whole development of modern psychiatry, drugs have become available, and people say, we'll try them with children with autism. And it's not a very promising record, I can tell you. And the end of that process is that there are a few groups of drugs which are used to some extent. There's the SSRIs, the selective serotonin reuptake inhibitors. That's Prozac and its relatives, Prozac, fluoxetine, citalopram, drugs of that category, which are widely used, obviously, with adults with anxiety and depression, and have been used with children with autism, and indeed children with anxiety and depression. It has to be said that the record is worse in relation to children in general, to the extent that there's been a warning by NICE against using SSRIs in children in general, but particularly in relation to children with autism, because the adverse effects generally outweigh the benefits. That's not to say that some children may not benefit from them, but on balance, looking at the whole field, the studies are not encouraging in terms of the value of those sorts of medications, which is a bit of a disappointment, because actually some of those drugs can be quite useful for adults, particularly with OCD, say, or as well as anxiety and depression, but they seem to be less useful in relation to autism, and therefore there ought to be a greater resistance to being used. Mood stabilizers, so-called drugs like sodium valproate or carbamazepine, which are used in treatment of epilepsy originally, but have had some sort of use in relation to mood disorders, and may be helpful for some people. And then the most contentious area is the use of the atypical antipsychotic drugs, particularly for extreme forms of challenging behaviour and self-injury. And it has to be said, there's, the NICE guidelines make this very clear. There is no drug, none of these drugs, antipsychotics, have been licensed specifically for the treatment of children with autism. But there is an acknowledgement of their possible role in extreme conduct disorder with aggressive manifestations. And in that situation where the guidelines are very clear about this, where everything else has been tried and not worked, or when the manifestation is so severe, children are injuring themselves, which as we know they can, to the extent of causing very serious damage, then these medications can be used, but one needs to be extremely reticent about embarking upon that. I emphasise this reticence. I don't know if people have been involved in these sort of multidisciplinary team meetings with psychiatrists about how to manage children, because it always starts off with a few pieties, drugs are not the answer to this problem, and then the entire discussion then is about drugs and what dose to use and which drug. There's a sort of which reflects a sort of, it's not just parents that get desperate, professionals get desperate too, you know, because I think if only something could be used. The evidence for it is just not good. But that said, if you're going to do it, you've got to do it with a very clear idea. What exactly are you trying to achieve? What is the target behavior? How are you going to measure that, you know, precisely? Episodes of self-injuries, but episodes of, you know, properly, there has to be proper data on which decisions are made. With a proper period then, 3 or 4 weeks to examine, you know, to judge what's happening here. Is it helping at all? Side effect profile, because obviously the side effects of all these things are very considerable. And then with a clear recommendation at 6 weeks to sit down and say, look, is it working? Is it not working? If it's not working, to stop it. Because one of my enduring experiences, both as a parent, I can say it with real feeling, but also as a doctor, it's like turning around one of these super tankers to stop a medication once it's started. You know, it's so easy to start a medication, incredibly difficult to stop it. But the NICE guidelines are very explicit, and thank God for them in that respect. They make it very clear. If it's not working, don't carry on with it, because these medications do have significant long-term adverse effects, and you know, you might bear that risk if you're getting some benefit, but if you're not getting benefit, it should be stopped, and that should be properly monitored. So that's, you know, my 2 pennyworth on the drug question and on the various sorts of intervention. I'd just like to I'd like to leave a bit of time for people to comment and to have some wider discussion. I'd like to leave you with 3 aphorisms that I found very helpful, and you know, coming to the end of a long and tired career in medical practice. 3 things that I found particularly helpful. Lorna Wing, a very great woman who died last year, one of the founders of the National Autistic Society, the person who defined the concept of the autistic spectrum and the autistic triad, a pioneering researcher, parent of a daughter with autism, and a leading scientific world authority in autism. I remember hearing a lecture from her, which I was very lucky to attend in my early days as an autism parent, and she made the point, there's nothing autistic children do that is not done by normal children. I know the word normal's a bit out here, but Lorna wasn't one for political correctness. So nothing autistic children do that is not done by normal children. I think that's very important. Normal children do some very strange things. And, you know, that's part of being a child, and it's important not to overreact in relation to that and to have a sort of sense of that. This really brought home to me a while ago. A mother came into me and said, I'm really worried about my daughter. I'm worried, I think she's developing gender dysphoria. And it transpired that she'd been on the internet, of course, the source of much problems in life, as well as much enlightenment, of course. But she'd read a paper by Simon Baron-Cohen's team in Cambridge, which had identified gender dysphoria as an issue among young women with Asperger's syndrome who turned up at the clinic at Cambridge University. And I said, you know, what's happening here? How old is your daughter? She's 6, and she likes dressing up as a boy. You know, I said, you know, and you sort of think, well, the world's gone mad. You know, that in a way, that sort of resort to medical labels to deal with familiar action. And you sort of almost feel sad that one of the most delightful features of young children, love dressing up, is become pathologized in a medical diagnosis, which is simply just a nonsense thing in relation to a 6-year-old, and having no sense of, you know, what's appropriate behavior. A 6-year-old might be considered a bit more strange than somebody who's 25, you know. But so I think that's sort of, and you know, the sense of what's normal or what's typically developing is very important. You know, one of the diagnostic criteria that was talked about this morning is repetitive and restricted behavior under the new criteria. Well, I was reading a study of if you study normal, typically developing toddlers, more than half of them will meet diagnostic criteria for autism according to repetitive and restricted behaviors. You know, it's not very helpful in taken in isolation, and that's one of the things about, you know, you sometimes feel that the medical scientific world, a professional one in relation to autism, has a problem of weak central coherence, you know, not being able to see the wood for the trees, of extracting one particular thing and not seeing it in the wider picture. And Lorna Wing had a great sense of the wider picture. The thing that she always emphasised above all was the social character of autism, the social impairment, which is so distinctive. And it's so, whereas those sort of behaviours in a typical toddler would be very common, social withdrawal or social disengagement is actually very unusual in a toddler. Toddlers are highly, something great delights of toddlers, how social they are from a very early age. I always remember being very struck with my son, taking him to parks, playgrounds in parks, that you would sense, my son looked perfectly, typically developing, rather beautiful little boy, though his mother would say that. But you'd see children would approach him and very quickly they'd say something wrong here, something funny. And the parents wouldn't notice at all. You know, the children picked up on it, something odd about the affect, something that didn't want to engage in their play things, you know. And you sense that social thing of children so much more important in terms of seeing what's abnormal and what's normal. Donald Winnicott, and I'll say the other thing about Lorna Wing. She could be rather abrupt. I remember after the fifth person who talked about Asperger's syndrome in some conference, she said, Asperger, it rhymes with hamburger, she would say. And she was the person that, you know, kind of popularised Asperger's syndrome, but she didn't like to have people mispronouncing it. The second aphorism I'd like to quote is from Donald Winnicott, another very great figure, one of the child psychiatrists, psychotherapists of the post-war period. He died I think in the late 60s or early 70s. And he was one of the early pioneers of psychotherapy in relation to children. He worked for 40 years in a clinic in Paddington, actually worked in a clinic in Hackney as well. So we're rather proud of him in Hackney. And he wrote some very good books which are rather neglected now. But he made this point, which really struck me as very profound and so out of kilter with contemporary notions. Doctors should never interfere with a family that is a going concern, not even for its own good. Well, you know, that's an interesting thing, isn't it? And Winnicott had this very profound idea that doctors and nurses, he also included in this, think they know about how parents should bring up their children. He said that they haven't got a clue about it and they should stay out of it. The doctors know about certain medical things and they're entitled to advise people about medical things. They're not entitled to pontificate to people who probably know more life experience than they have about the particular difficulties of raising children, which is a subject about which they actually know very much less than they think they do. There's a certain humility and circumspection about interfering in families is something people should cleave to in the medical profession. The third aphorism comes on what you might regard as slightly more dubious authority of Elvis Presley and Clint Eastwood. But actually, I think it goes back much further than they say, and it's become a sort of cherished maxim of the world of evidence-based medicine. And this is, don't just do something, stand there. Don't just do something, stand there. And that's particularly become important in the world of evidence-based medicine because it took about 2,000 years for the medical profession to realise that much of what they did actually, far from doing good, actually did harm. You know, all that bleeding and purging. And it was only about 50 years ago that medical interventions, on balance, probably, you know, did more good than they did harm. And so there's a certain sense of, you know, that you should be careful about what you do, you know, about the interventions that you make in terms of a medical treatment or even a social type of treatment. You've got to ask yourself two questions, and this is obviously guides the whole world of evidence-based medicine. Does it work? You know, do you know that it, particularly in relation to medications, have you got evidence that that drug produces the effect that you desire, and is it safe? Do you know that it's safe to do that? And if you can answer those two questions, then you can, you know, you've got some basis on which to proceed. And the simple fact of the matter is that we don't know the answer to those questions in relation to very much that goes on in the world of autism and mental health issues. And, you know, we tend to, you know, you take an idea like early intervention. Everybody has this idea that early intervention is, the crucial, early diagnosis is absolutely critical, early and intensive intervention is of the essence, and people say there's very good, there is not good evidence for any of that, actually. There's no good evidence. Michael Rutter, the preeminent child psychiatrist of recent years, explicitly made this point a few years ago. There's no good evidence to support the value of any particular therapeutic intervention in relation to children with autism at an early age. And all these pioneers, promoters of various sorts of intensive educational behavioural techniques claim great benefits for them, but highly doubtful. And the other side of that is you need to be aware of not only the question of whether it's effective or not, but actually you can do harm by intervening. And that's one of the things that I think came out of some of the early discussions. You can do harm by labelling things inappropriately, by embarking on treatments which may not work and which may, be a substitute for doing other things which may be more useful. You've got to be careful about some of these things. And that maxim, don't just do something, stand there. Be there for people is the important thing sometimes. And sometimes, in life, in schools, in the general practice surgery, people tell you things. They don't actually need you to do something. They just need you to be there for them. And being there for them in the long run may be more helpful for them. Thank you. Now, I don't know, we've got a microphone if people want to ask any questions or make some points or violently disagree.
Can you say who you are as well, please?
Oh, I'm sorry.
No.
Oh, my.
Sorry. I'm Helen Anderson. I'm Action for Children. I guess there's just a couple of things I wanted to say. One that I would say thank you to you for is that I will always say hamburger first, because I probably have been saying it wrong. You made a point about the third quote about the doctor and about the medical profession not interfering in family life. And I guess the only little thing I wanted to say about that is my concern would be that might be partly, one of the reasons that you're the only GP here. Really, if you think, because actually I think we do need the medical profession to get involved more, not less. My question, was just to ask you your views on methylphenidate and ADHD, just because that was one of the medications that you didn't mention.
Yes, methylphenidate and atomoxetine are the two drugs used in relation to ADHD. I don't know, to tell you a story about methylphenidate. I was involved in a trial done at the Maudsley as a sort of parent representative did a controlled trial of the use of methylphenidate and atomoxetine in relation to children with autism and ADHD, which added to a growing body of literature which finds it very difficult to decide which is the most beneficial. There's some benefit to both of them. They both have side effects. Some of the studies suggest that atomoxetine has more side effects than methylphenidate. Some of them show the other way around. So I think the jury is out on what is the most effective. But I think there is little doubt that methylphenidate, is the first. That's Ritalin. People are not familiar with it historically. Is quite effective for symptoms of ADHD, used in very circumspectly. And I think one of the issues that always arises with ADHD, and it certainly arises in the relationship between primary healthcare and secondary healthcare, is who's responsible for the prescribing, who's monitoring the benefit, who's monitoring the side effects. That needs to be very clear, and the dosage needs to be very carefully monitored and regulated. And I think all the good clinics that do that will emphasize that side of things. But I think which of the drugs is most effective is a difficult judgment. I think above my pay grade making that distinction, I think, in terms of any particular child. But I think there's no doubt that it helps with some children in terms of sustaining attention, particularly in school situations.
My name's Sam. I'm a social worker in a disabled children's team in Enfield. some of the most difficult conversations I have with parents are when they're telling me that they're being hurt and hit by their own children. And I suppose just some perhaps more personal advice rather than your professional advice. What would be the most helpful advice if you were calling up and saying, my child's hurting me? What kind of help or intervention would be best appreciated?
Well, it is difficult, and I think the Challenging Behaviour Foundation has a useful organisation in terms of advising. But there are particular techniques, just on a practical basis, particular techniques of restraint, which you need to use very circumspectly, but also techniques to minimise injury to yourself and to other family members. Is a useful thing. But I think it really comes back to the broader issues. It's identifying triggers, it's identifying reinforcing factors, it's preventing the episodes rather than, because once it's happened, it's very difficult, and you've got to try and contain it as best you can. And there's no question it can be very difficult. But I think you're apart from identifying that, you're going back then to your psychosocial, your therapeutic, your medication. Ultimately, if those don't work, then it's worth trying the medication. Some people certainly find the medication does help with the self-injury and the aggressive behaviour. It can help. I can't say my personal experience has been tremendously encouraging. But one of the things you've learned from evidence-based medicine is the doctor's anecdote's a very dangerous thing. The evidence suggests that there is some benefit that can be had from those things. I think while that's going on, the other can be a real problem, which I've certainly come across as a GP, is the challenging behaviour between siblings. When you've got an autistic child who is attacking a younger sibling, that can be a very difficult problem. And it's particularly when you get a very aggressive boy attacking a younger child, where there's no sense of remorse or recognition of the problem, and an almost you get a sort of worrying sense of how far they'll take it. I've known that sort of situation only be resolved by residential school, because I think that is a very real issue.
Hi, I'm Maggie Butler. I'm here as a specialist teacher for autism from Essex, but I have a son with ASD and various other conditions, who's now 34. He's been on antipsychotic medication since he was 19. He's been on Abilify for many years. I can't say the long, that one. I was just, he has got extremely aggressive behaviour and has been, aggressive in the community and so on. He's in residential care with the NAS, actually, very successfully. Just wondered what your views were on the long-term usage of antipsychotics. He's now having anger management, so would there be a time when, anyway, that's the kind of issue.
Yes, well, that is a very familiar set of issues. I think the frontline drug in recent years, these things, it has to be said in the psychiatric, go in real fashions. The atypical antipsychotics came in as an alternative to the old traditional heavy-duty tranquilizers that were the sort of largactil, chlorpromazine, trifluperazine, the drugs that emptied the old asylums from the 60s and 70s onwards. Those drugs all caused these extrapyramidal tremor-type side effects very, very badly, premature Parkinson type developments. So then this whole thing developed from the 80s and 90s onwards, what they call the atypical antipsychotics, which were antipsychotics which dealt with, and these all developed in relation to schizophrenia. So that were good for schizophrenia, but didn't cause the Parkinson problems. So they all came in the 90s generally. Risperidone was one of the main ones. Clozarine, I can't remember the names of it. Clozapine is the very successful one. You have to have blood tests all the time for that. But They have been quite successful in relation to schizophrenia. The trouble is they do have very considerable side effects of a different sort. They don't seem to cause the tremor so much, but they cause diabetes, particularly weight gain. That everybody's on them like Michelin Man, and you're lucky to have avoided that. Aripiprazole causes that rather less than risperidone.
He never sits down, so.
Yeah. Well, but that's the problem with them. They cause the list of side effects is prodigious, but the main one is weight gain, then a diabetic tendency, then certain cardiac problems, which is most severe with clozapine, cause ECG abnormalities. So, and it has to be said, they've been, they're a bit better than the traditional, but not all that much, And in relation to challenging behaviour, which is the thing we're talking about now, risperidone has been the one that most studies have been made of. Risperidone, as I said before, does seem to have some benefits in relation to self-injurious behaviour and aggression. It does cause weight gain and some of these other symptoms. Aripiprazole is a relatively newer, slightly more subtle, causes less side effects. It's not quite clear whether it has the same effect, but it's come into use as an alternative to risperidone because it has less side effects. So I think, one of the things, the older you get as a doctor, the more cynical you get, I'm afraid, about drugs, because they all come in with a flourish, it's going to be great. And, a few years down the line, it's discovered it's not that great and it's got side effects. So it's always a bit, none of them ever live up to the hype, I'm afraid. But, it can help. And a little bit of help in the sort of situation that you describe is worth having. So, I think with all those caveats, we have to carry on using them. But there is always the long-term. The issue of side effects does, I'm afraid, increase with the longevity of use. There's no escaping from that. Well, I think if there's no... somebody else at the front here.
I was waiting to make sure that nobody else had a question. I don't want to take up time. So my question is, the last point you made in your presentation I thought was really important, about that sometimes as a general practitioner, as I understand what you said, was that you don't actually need to do anything. You just need to be there for the person. That sometimes actually, you could do more harm than good intervening. You need to make a judgment about it, and sometimes it's just about being there. I've worked as a mentor with people on the spectrum, and the majority of people, I haven't met everyone on the spectrum obviously, but the majority of people I've worked with, and primarily with people without learning disabilities, I've seen that there seems to be a very big kind of hole in service in terms of they don't necessarily want someone to do something. They just want someone to listen to them. And I wondered if you thought from both a health point of view and a support point of view, but also in terms of a positive economic argument, whether you thought that the health service and social services ought to work towards having some sort of listening service with people who are able to see people on the same person, not like a duty social worker, but somebody to listen that doesn't necessarily do anything but will listen to you, but not like a counsellor, someone that could give you advice and practical information.
Well, I think it's a great idea. The trouble with it is, to go back to the issues of general practice, it's not going to happen in general practice the way things are at the moment. I'm afraid general practice is being systematically reorganised around the demands of the worried well. And that means that at the end of the queue, we know who's going to end up there. The problem of trying to provide, and I only yesterday I've been in discussions with one of the founders of the National Autistic Society, whose son is now 60 and he's in his 80s, who is writing a chapter for a book about autism and ageing. And his preoccupation is, what can we do to improve the level of GP care for people with autism who are now ageing and getting into that kind of and have significant medical problems. And I have to say, my heart sinks at the discussion being raised, because I just know when I go back to see my former colleagues in general practice that the problems of people with autism and learning difficulties are being forced further down the list of their priorities rather than further up them. And the way things are going, the whole politicisation of general practice and everything else, I fear things are going in the wrong direction. But what you suggest would obviously be not only beneficial for people, it would obviously in the long run, save a lot of money, particularly in terms of, because mental health breakdown, and this is like the problems of social care at the moment. My wife and I are currently engaged in a major campaign in our borough of Haringey because the council is closing down in the great austerity drive the whole of adult social care effectively. And what that's going to mean is the care packages for many adults with autism and learning disability are going to be cut back. People are going to be thrown back on the care of their families. Care arrangements are going to break down and they're going to end up in Winterbourne View. And, it's one of the things about Winterbourne View, if people are following this thing, that 2 years after the whole Winterbourne View review and the idea was to get people out of those places, there are more people now in them. And this is like, how could that happen? Well, everybody knows why it happens, because there's nowhere in the services in the community don't exist to support people in that. And that's the great problem that we're grappling with really now, and what we've got to, and I say unfortunately the position, and that's why there's no GPs here. GPs they're just ground into the ground, I'm afraid. And so their capacity to help with problems of the sort that we're talking about, I'm afraid it's receding. It's very depressing, I'm afraid. If I could just say one thing finally, a great, I know the that is a product placement for the National Autistic Society, a great organisation. Your Autism magazine is a great supplement on ASD and mental health issues, which I strongly recommend. The best thing about this, let's just say very briefly, it's got some great case, you read these glossy guideline type things with case studies and all that, and they say, they're all full of little glossy, I was referred to a psychiatrist, it changed my life, I went to CAMS and it was brilliant. This is full of case studies where you said, I was referred to a treatment, it was a bit rubbish, but I've pulled through. That's the real world, It helped a bit, but that's...